Um, yeah. So hi everybody. I am Ahmed Halawa. I'm a consultant transplant surgeon.
دكتور احمد بعد اذنك لو سمحت لي هقدم حضرتك يعني دكتور ياسر هيقدم حضرتك يعني قلت لك يعني
1 minute just.
اتفضل يا دكتور ياسر.
بسم الله الرحمن الرحيم. Welcome everyone back to our CME activity of Egyptian Society of Nephrology and Transplantation after our highly successful conference that was made last month. Today we will start by the activity of transplantation chapter and headed by Professor Ayman Rifai, who is the moderator of this session today. Professor Ayman is the President-elect of Egyptian Society of Nephrology and Transplantation, Chief of Nephrology and Transplantation Unit in Urology and Nephrology Center, Mansoura University. And our speaker today is Professor Ahmed Halawa, who will be presented by Professor Ayman. Please, Professor Ayman.
Thank you very much,
Professor Ayman, please start.
Introduction. Thank you very much, Professor Yasser, for this kind introduction. I would like to welcome everybody and to thank our dear brother and friend, Professor Ahmed Halawa. I think he's a well-known figure for all of us with his great scientific contribution for the Egyptian Society of Nephrology and Transplantation, either in the conferences or in his high-quality scientific materials that he's always presented and published in our journal of the Egyptian Society of Nephrology and Transplantation. I would like to thank him very much for his continuous contribution. As we all know that Professor Halawa, the consultant transplant surgeon at Sheffield Teaching Hospitals, and he's the program director of postgraduate education and transplantation at the University of Liverpool. And he's also the program director of the fellowship of the clinical transplantation organized by the Arab Society of Nephrology and Renal Transplantation. I would like to thank him also for choosing this very important and hot topic in management of kidney transplant patients, which is the fluid management in the peri-transplant period. Actually, this is a major challenge for the clinician and transplant physicians, and this has been shown to improve the post-operative or transplant outcome. As we all know that fluid and electrolyte replacement during the peri-transplant period aims to maintain an adequate intravascular volume to ensure renal perfusion, so immediate graft function is optimized. And to achieve this goal, an adequate understanding and management of fluid therapy is essential in such major surgery, which is, as we all know, associated with renal insufficiency and electrolytes and acid-base disorders. And also, as we know that optimal fluid therapy has been shown to decrease the delayed graft function after transplantation. So the primary goal in the perioperative setting is to avoid tissue hypoxia and the major causes, which is the major cause of the organ dysfunction. So we are expecting that Professor Halawa is going to discuss the different perioperative fluids used and also the assessment techniques, both conventional and novel monitoring strategies in kidney transplant recipients. Please, Professor Halawa, we are all excited to hear your presentation. Please, Professor Halawa.
Thank you, Professor Ayman and Professor Yasser, for this nice introduction. Really, I totally agree with you that fluid management is an essential part of transplantation. without proper fluid management, transplantation will never succeed, but also it's quite debatable as well. As we will see, there's no strong evidence in many aspects of the peri-operative fluid management, and the evidence are not quite strong as well in many parts of the talk, and this is what we are trying to address. I would like to address an important point here. Medicine never been based on prospective, randomized, multi-center, double-blinded controlled trial. Otherwise, we cannot practice medicine. Medicine itself, transplantation in particular, is a case report. The one who decided to put the kidney in the right iliac fossa, he tried it and it did work, never based on randomized trial. But this is what we have. These are the evidence, and this is why we are here, to discuss this evidence, to discuss the practice as well, various aspects of our practice, and start questioning, are we doing the right things or not? The objectives of this talk is to stress on the importance of adequate fluid balance and its impact on the outcome of renal transplantation. To highlight that fluid overload is more detrimental than less fluid. I would like to remind you, on day 3, day 4 post-transplantation, the weight of the patient. You'll discover that the patient, in many occasions, is 10 to 12 kilograms above his dry weight or the target weight. Challenges in monitoring the transplant intra and post-operatively. Also, we need to address an important aspect of this talk is how to enhance the patient recovery and to improve the quality of care, of course, by adequate fluid management. I will start by giving you this scenario: not passing any urine. A 34-year-old CKD5 patient who had kidney transplantation from a living donor just yesterday. As usual, the kidney started to pass urine on table. 18 hours later, you were informed that he did not pass any urine for the last 4 hours. As a senior clinician, this is not an unusual scenario because the junior staff will try to treat this. Most of the causes behind this scenario, most of the time, are non-surgical. I would like to have a look on the right-hand side of the slide. It could be a blocked catheter. And I will tell you a very funny scenario, short scenario, where the catheter would rechange immediately after the operation. Next day morning, the patient is not passing any urine. Actually, we discovered that the nurse put the catheter into the vagina. It happened twice in my career. During the ward round, not passing urine in a young lady, and the catheter was in the wrong place. Of course, our main concern is rejection, especially if you have highly sensitized patient or ABOI-compatible transplant. CNI toxicity, however, this is less likely on day 1 after transplantation. Usually, CNI level is quite low. Prolonged warm and cold ischemia time. This is true for deceased donor transplant, cadaveric transplantation, DCD, donation after cardiac death, donation after brainstem death. But as I mentioned early on, if you look at the right-hand side of the slide, please check the fluid balance. Fluid chart, input, output, how much in the drain. Was the patient vomiting? Roughly how much he vomited. Don't forget this patient had 3 to 4 liters of intravenous fluid in theater. Just look at the anesthetic chart as well to see how much fluid he got in theater. What was the expected and what was the documented loss in theater as well. So the life of patients, the journey of the patient did not start when the patient comes back to the ward, but starts in theater. Most of the time, you'll find good documentation, but sometimes it didn't come to your mind that this patient had 5 liters in theater, or he lost significant amount of blood in theater, difficult transplant. Surgical causes, after excluding the non-surgical causes, which is quick. Ultrasound scan usually is enough because it will detect collection, whether kidney perfused or not, any hydronephrosis. However, I would like to remind you that most of these kidneys will demonstrate mild hydronephrosis. Remember, it's a denervated kidney. Renal artery stenosis, kink or something, and this can be detected by the perfusion, reduced perfusion. Sometimes the ultrasound scan is inconclusive. Very obese patient, very dark, deep hole, small kidney, ultrasound scan sometimes inconclusive. If inconclusive, contrast CT scan. Come on, contrast CT scan in a transplant done a few hours ago. What about contrast nephropathy? We used to say here in UK, penny wise, pound foolish. We try to avoid contrast nephropathy in the expense of missing major surgical complication, which could be damaging to the kidney, or could be bleeding, which is life-threatening. So you see the contrast nephropathy at the thread, like the tip of the iceberg, but the main body of the iceberg, which is huge, is under the water. Try not to save a penny to lose a pound. By the way, 1 English pound is 100 pennies. Let me change the scenario, give you a different scenario. Passing loss of urine. A 34-year-old CKD5 had a kidney transplantation from a living donor just yesterday. The kidney started to pass urine on table, as expected. 6 hours later, you were informed that he's passing 1.5 liters to 2 liters per hour, which is being replaced hour by hour. Does this make you happy? Of course, you are happy because the kidney is working. But I would like to remind you that you are treating a patient, or with the kidney inside this patient, and this patient has heart, liver, lung, blood vessels, circulation, tissues, bowel, bladder, urinary system. So try not to be pleased with yourself and try to treat yourself by disturbing the electrolyte balance of these patients, by messing around with his acid-base balance. Again, you need to check the fluid balance. Something is not right. Something is wrong. Maybe you're giving unnecessary diuretics in theater. Sometimes we give furosemide, we give mannitol for various sort of reasons, just to see the kidney functioning. However, this furosemide or mannitol may be not required because the indication of diuretics here is fluid overload. If it's fluid overloaded, of course, diuretic takes place and plays an important role. Mannitol has no role at all in preventing the effect of ischemia reperfusion injury. It's been confirmed over a long time that it's not scavenger anymore for the byproducts of ischemia reperfusion injury. Perioperative fluid management is a minefield. Don't leave it for the inexperienced staff. You have to be very careful, and you have to interfere promptly when anything starts to go wrong. One or both of the scenarios I mentioned early on, this should trigger the alarm to interfere. Something is not right. Again, strong evidence in transplantation is lacking. So let us go through some facts, and I would like to remind you and refresh your memory with the basic physiology. The main perfusion of the kidney is linear with the mean arterial pressure, not the systolic, not the diastolic, not the pulse pressure, but the map. It has been shown that if you run it between 70 and 80, even higher, this will ensure adequate kidney perfusion. Of course, all of us agree that fluid replacement is better than none in hypovolemia, regardless of the kind of fluid. If you have hypovolemic patients, he should have fluid, regardless of the type. Fluid management in AKI, DGF, should not be different from fluid management in critically ill patients. But remember, critically ill patients are definitely more ill that will adopt the principle of fluid management in critically ill patients in the perioperative transplant period. Fine, let's just go through the crystalloids. The half-life is not more than 30 minutes in the intravascular space. You won't stay long in the intravascular volume. We know exactly what will happen after infusing 1 liter of crystalloid in the next slide. If you have a major bleed affects the microcirculation as well. This cannot be compensated by crystalloids. It has to be blood. Regarding colloids, no evidence whatsoever from RCTs, randomized controlled trials, in support of colloids in critically ill patients due to the following side effects: renal impairment like HES, coagulopathy, dextran, allergic reaction, dextran, high potassium content, gelatin, cost, albumin. These fluids are more expensive, associated with side effects, of no use, no confirmed benefit, even there are many side effects. So not recommended. Balanced crystalloid solution are better than normal saline in major surgery. It's better for the acid-base balance. It's better for gastric perfusion. It's better for hemostasis. It's better for the renal function. And I will explain what's meant by balanced crystalloid solutions later on. The only benefit of diuretics is to get rid of extra fluid in fluid overload. It's not to please the surgeon that the kidney is functioning and is passing lots of urine. We are disturbing the internal environment of this patient. Infusion of 1 liter of normal saline. What happens? Nearly a quarter of this liter, 275 mLs, will go into intravascular volume, into intravascular space. The rest will leak into the extravascular space. You could have edema before repleting the intravascular space. You have edema and the patient is still intravascularly depleted. Let us have a close look to the normal saline. pH of normal saline is 5.7. Orange juice is 4.2. So normal saline is as if diluted or mild orange juice. Imagine you are infusing diluted orange juice into the circulation of this patient. Normal saline is abnormal saline. Nothing normal with the normal saline. Fiona Reed and her colleagues demonstrated clearly that the high chloride content of the normal saline is behind the abnormality of the normal saline compared to Hartmann. Hartmann is much better, more physiological, because the sodium chloride ratio in Hartmann is much better. And they tried this in healthy volunteers. More acidosis in healthy volunteers given normal saline. Still, we are exploring facts and refreshing our memory with facts. pH of Hartmann is 6.7. So it's much better than normal saline, very close or closer to the normal pH. The reduction of the pH by 0.1. So on the acidosis side, increases potassium by 0.7 millimole per liter, 0.7 milligram per deciliter. Am I comparing normal saline, which has no potassium, with potassium containing solution like Hartmann? And you're giving this to a patient who has renal failure? Of course, yes. And you will see that Hartmann is more physiological, much better in terms of potassium profile and acidosis profile and acid-base profile compared to normal saline. So if you infuse 1 liter of normal saline of Hartmann, which contains 5 millimolar of potassium, this will increase the potassium concentration. This is by just calculation by 0.1 millimole, 0.1 milligram per deciliter after 15 minutes. Is it true? No, it's not true, because Hartmann has something else which is important. The bicarbonate, the buffering effect of bicarbonate, which is definitely therapeutic in case of hyperkalaemia due to acidosis. In fact, Hartmann, in spite of containing potassium, has a tendency to induce hypokalaemia by increasing sodium delivery in the distal nephrons, distal tubules, in exchange sodium. For the sake of honesty and clarity, Kayevi and colleague reported 2 cases of renal artery thrombosis in patient treated with Hartmann. But be aware, it could be king, it could be coagulopathy, it could be technical. We cannot blame the Hartmann. Exactly like a surgeon, something goes wrong, start to blame the assistant, the nurse, the light, the environment, the weather, start to blame everybody around him except his crap technique. But we have to agree that better control of acidosis improves kidney function, creatinine and urine output. And this is our target, to control acidosis. Once acidosis is properly controlled, less likely to get hyperkalaemia. And what's wrong with hyperkalaemia? Of course, in the immediate postoperative period, it will be messy to arrange dialysis, or you give furosemide, big doses, and especially for DCD or cadaveric transplant, the kidney is not functioning, furosemide may not work, so you have to arrange dialysis. Is it heparin-free or was heparin? Heparin means bleeding. Heparin-free means you're clotting the circuit. Challenging. Will you dilate this patient in the recovery? Is a mess. Better to avoid it by adequate control of acidosis. Now we come to few definitions and some understanding what's meant by balanced crystalloid solution. Of course, a common sense balanced crystalloid solution is a solution which its composition is very close to the plasma, which minimally derange the acid-base balance. They went that far to define balanced crystalloid solution, the one who has low chloride content. It looks like the high chloride content of the normal saline is the criminal, is the one which is causing trouble. And this is true. The high chloride content of normal saline will induce hyperchloraemic metabolic acidosis, subsequently hyperkalaemia. So again, back to the previous slide, tight control of acidosis will ensure better kidney function and good urine output. Preoperatively, dry weight. We use this term like chewing gum. I can challenge anybody who can tell me the right dry weight for this patient. The problem of renal failure patients, especially hemodialysis patients, they can hide liters and liters of fluid without being clinically apparent. They could be edematous, but intravascular depleted, could be dehydrated in spite of edema. We should pray to Allah that He provided us with 2 dialysis machines working 24/7 for the rest of our life, controlling the internal environment without messing around with heparin circuits, line, fistula, and their associated complications. It's well-known fact and based on large American cohort and case control studies that there's high incidence of DGF following transplantation in hemodialysis patients compared to peritoneal dialysis patients. They attributed the high DGF delayed graft function rate due to hypovolemia in hemodialysis. And this is true. I see it as a surgeon. You know, sometimes we spend hours before getting the patient volume repletion. And during the operation, you can see collapsed vein. But peritoneal dialysis, the situation is different. They have residual kidney function, which could mask the DGF, but this is good for the patient. This will allow us to control his fluid balance better because there is some output from his own native kidneys. And of course, this will mask any signs of DGF clinically, but biochemically, creatinine is still rising. So it's definitely DGF, but it's still passing urine. Yes, because we are challenging his native kidneys. They still produce some low quality urine. Intraoperatively, I will refer to Osman et al. From Mansoura, who published a nice article in Anesthesia and Analgesia in 2010, which showed clearly that bolus infusion, biphasic infusion is better than constant infusion before declamping. This means before taking the clamps off, you ask the anesthetist to push more fluid. This gives better graft function. These patients require fewer pressure, fewer diuretics, less postoperative tissue edema. Fine, let us put it into context. Normal saline versus lactated ringer, Hartman, in living transplantation. This is another landmark article published long time ago by O'Malley and her colleague. It's a randomized trial demonstrated that significant hyperkalaemia happened in normal saline infused patients, more significant compared to lactated ringer, Hartman. Significant metabolic acidosis in normal saline group compared to lactated ringer group. No significant difference in graft thrombosis between both groups, normal saline and lactated ringer. No significant difference in kidney function between both groups. All biochemical, but important because hyperkalaemia is not a benign condition. Acidosis as well is not a benign condition. Actually, metabolic acidosis can cause graft thrombosis. What about deceased donor transplantation, cadaveric transplantation? This is a nice randomized trial in 2017, which demonstrated that the plasma light is a balanced electrolyte solution, something like Hartmann, like lactated ringer, is much better than normal saline in terms of hyperkalaemia, in terms of acidosis. Remember, I will be back to Osman and colleagues. Intravenous fluid should be considered like drugs with indications, contraindications, and side effects. Please don't grab a bag of fluid from the shelf and give it to the patient without knowing what you're doing. Side effects, indication, contraindication. It's like a drug. Now we're moving to monitoring fluid in kidney transplantation. It's really a black box. Again, evidence is not robust. And we have to think about it. Of course, many use CVP, central venous pressure. In theater, I would like to give you the picture of what happens in theater, and I will ask you a question, and I'm expecting one answer. Sorry, I'm not democratic in this situation. The patient is tilted to one side. There's big abdominal incision. Two hands of the surgeon and two hands for the assistant inside the abdomen. Packs, retractor. Some surgeons put the head down in order to pull the bowel away from the operative side. Don't forget this patient has post-pressure ventilation on a ventilator. And then the surgeon turns his head to the anesthetist. What the CVP? Do you think the CVP is accurate here? The position is not right. The head is down, positive pressure ventilation, and all this pressure inside the abdomen. This is reality. So CVP, of course, will be misleading you. I would like to invite all of you to read this article, a systematic review of literature, The Tale of Seven Mares. Is one of the leading articles. A systematic review conducted by Marek and his colleague. They demonstrated clearly that there is a very poor relationship between the CVP and the blood volume, as well as the inability of the CVP and the changes of the CVP to predict the hemodynamic response to fluid challenge. Remember, we were taught, provided that the CVP kept rising, means patient needs more fluid till it plateaus. Actually, they demonstrated clearly that the patient reached and become overloaded, but the CVP is still rising. So this is, the plateau of the CVP when the patient is adequately filled is a lie. Is it true? And systematic review. So it's a good evidence. Not only Merrick, but also Kumar in critical care. You can see these articles, these evidence are quite old, but they didn't stimulate us to change our practice. It will take a while to change our practice. Our human feeling is we are fear of change. Anyway, both of them demonstrated that the increasing evidence that the CVP does not correlate with the ventricular volume, the preload, or the volume responsiveness. And these said clearly should not be used as a guide of intravenous fluid therapy. Again, this is one of my publications. Shooting the CVP as a guide of fluid management in renal transplantation. And I referred this to this paper early on. In UK, it's rarely used. We don't use CVP anymore. I know what comes to your mind. What about you're talking about theater? What about on the ward? We'll discuss this later. The CVP should be buried. We shouldn't pray for it. لا يجوز عليه الصلاة. Fine. What are you going to use for monitoring? We use in Sheffield and most of the UK transplant centers, we use transesophageal Doppler. And this has actually been recommended by the NICE guidelines as well in August 2020. So the transesophageal Doppler reduces the postoperative morbidity associated with shorter length of hospital stay in patients managed with transesophageal Doppler compared to conventional clinical management, including the CVP. Not only the transesophageal Doppler, there are many other techniques. The second one we use is, sometimes this is based on the anesthetic preference, the LEDICO, lithium-directed cardiac output monitor in theater. We have to remember that each of these techniques has its own limitations. We have to be aware of these limitations. Don't forget, again, the fluid given to the patient in theater. This is part of the package. Fine. Fluid overload. I'll go back to the critically ill patients. It's been shown clearly that more than 10% increase in weight due to excessive fluid replacement is associated with 31% mortality. Less than 10%, the mortality in critically ill patients will go further below 10%. And the mortality and morbidity is due to cardiac, respiratory, wound healing, gut function. Again, this is summary of the bad effect of fluid overload on various organs of the body, including the kidney we're putting in. Fine, let's just focus on the kidney. We have to admit the studies are observational, confounded by the fact that sicker patients, critically ill patients received more fluid. And this is, again, a weak point in the evidence. But if you think about it, fluid overload causes intra-abdominal hypertension. Intra-abdominal hypertension increases renal venous pressure. Of course, it will reduce GFR and leads to AKI. In the absence of intra-abdominal pressure, high pressure hypertension, venous congestion reduces GFR and leads to AKI. So venous congestion itself, for any sort of reason, can cause AKI. In critically ill, they demonstrated the benign nature of less fluid, of fluid restriction. But we don't need to run transplant patient dry. So what we need is to get the balance right, adequately filled, not overfilled, not dehydrated. It's easy to say, it's difficult to achieve. Fluid restriction, as a matter of fact, is not a disease. In organ donation, it allows lung transplant. It protects the lung against neurogenic edema. Ensures better quality of the lung graft without causing damage to the kidney. So in multi-organ donor, you'd like to preserve the lung without damaging the kidney. So a restrictive measure is advisable. But fluid overload is a disease. It does not improve the outcome and the prognosis of AKI patients. It is detrimental. This is a picture of one of our patients, 14 kilograms above his what's called a dry weight, which obviously it was not dry, is not the right weight. 2 days after transplantation, you can see edema on the scrotum and the catheter. It was quite difficult for me to take the catheter in this condition, to remove the catheter. And the patient was in agony because of this plastic tube. Another picture, this is a young lady, 44 years old, living ready to transplantation. She was 6 kilos above the weight on admission because I don't like to say that dry weight, because obviously she was not dry. Just 6 kilograms, 6 liters, positive balance. Called this picture. Primary function. No study whatsoever demonstrated that the type of IV fluid, whether Hartmann, with whatever, normal saline, has affected the incidence of primary function. Again, no study showed that the type of fluid as well has changed or has an effect or influence on the DGF rate and graft survival. But it could be that balanced solutions are better in surgical patients and in AKI. For me, as a compromise, whenever it's possible, I ask patients to drink. Let the body deal with it. Our body is more efficient in controlling the internal environment. Drink and eat. It will be sorted. Fine. Some centers, but not in UK, use half normal saline as a fluid replacement. As a matter of fact, half normal saline is hypotonic. It can cause fatal hyponatremia. It's not popular in the UK. The good thing about half normal saline has low chloride content. Therefore, the incidence of hyperkalaemic acidosis is much less compared to normal saline. But fatal hyponatremia and brain edema is not a joke. What about monitoring fluid balance on the ward? How would you do it? Clinically, yes, you examine the patient, flow chart, check for edema. In a patient lying flat like this, check edema, not in the lower limb. Of course, you do this, the lower limb, but sacral edema because it's lying on his back. Vital signs could help. However, change in the vital signs could be a late sign. CVP, if you still believe in it. Transesophageal Doppler is not suitable at all for awake patients. Urine output, input and output. And the most important tool is a scale, الميزان, daily weight. Because if you, of the patient, put 3 kilos overnight, it must be fluid. It can't be flesh. It can't be fat. It must be fluid. We replace fluid urine output hour by hour, in addition to what's called insensible loss, which is calculated roughly between 0 and 60 mL per hour. But remember, in a warm weather, the insensible loss will be more. In a cold weather, the insensible loss will be less. Don't forget to put into your account the vomiting, the drain output as well. So be careful with the urine output plus sensible loss. Don't follow this rule blindly. Assess the patient. Fine. Just to get to the final part of my talk, we need to get the fluid balance right to enhance the patient recovery. This is one of my publication as well. We're lucky enough, we managed to implement enhanced recovery all over UK. The components of enhanced recovery, of course, proper fluid management, but this is not the only part of the story. Pain relief, no nausea and vomiting, no constipation, free plastic catheter tubes, no seizure medication. Patient should be mobile, knows the expected date of discharge. So adequate fluid management is an essential component of enhanced recovery. You wouldn't be sending patient who's 15 kilograms above his dry weight or the target weight home, because he won't be mobile. It could be nauseous, it could be vomiting because of edema of the bowel, it could be constipated, again, dysfunctional bowel. The drain could be productive because it's full of fluid. You can't educate this patient if he's unwell. He can't be mobile. He'll be bedridden because of bad fluid management. I would like to ask you, this is one of my patients, how many hours, how many days after the transplant will reach this stage? If you can see, he's mobile, no lines, no central lines, no drains, only a catheter bag. Walking, because this room is the one behind us. "18 hours after the operation. We managed to succeed with most of the patients, but not all of them. It depends on the mentality, educational background, culture, many other factors. Patients of Asian origin like to lie in bed and visitors around, part of the cultural heritage. Finally, catheter, urinary catheter. You keep the catheter for 2 to 7 days. There's no evidence whatsoever demonstrated that keeping the catheter for long will help. The opposite is true. The catheter is inconvenient. Plastic tube down your system, you can't mobilize well with the catheter, always irritating the bladder. Sometimes the surgeon would like to keep it for long just to enjoy watching the urine output. It's not fun here. We're not treating ourselves. We're not doing the operation to be pleased. We're doing the operation to please the patient. Of course, the duration of the catheter should be individualized. Thick wall bladder, difficult bladder anastomosis, very thin wall bladder. Of course, you can keep the catheter for long, but many patients have normal bladder. 2 days will be enough. Once eating, drinking, and start to be mobile, take the catheter out. Monitoring urine output. Yes, we have creatinine. Daily creatinine will tell you whether the kidney is working or not. He can tell you, he can collect the urine without a catheter. You give the patient a bottle and ask him, whenever you pass urine, just put it in the bottle. Could be difficult for ladies, but they do it. So my conclusion, balanced solution is better to give in the perioperative period. Cheapest one is Hartmann, lactated Ringer. Satisfactory fluid management is essential for fast recovery. CVP is worse than nothing. It could be misleading. If you're going to use it, don't use it alone. Should be used in conjunction with other clinical parameters. Think of how to get this patient better quickly to discharge him or have back home. I would like to remind you, hospitals are not clean, full of bugs, organisms, hospital-acquired infection, recently COVID. We have patient, acquired COVID in hospital. Prolonged hospital admission is not good for both the patients or the health organization. It costs money, staff, burden on the NHS. Give the patient leadership of his care. Fine. I will ask you a few questions, if you don't mind, and feel free to do mistakes. I do mistakes all the time. MCQ 1, renal perfusion is directly related to the systolic pressure, linearly correlated with the mean arterial pressure, can be monitored accurately by the CVP, inversely related to the pulse pressure, better in upright position. Yeah, I see very smart colleagues here. Nahla, Mahmoud Islam.
They are, yes, actually they are. Yes.
Yeah.
Very smart.
Ooh.
Very smart.
Yeah. Fine. Second question. Which statement is true regarding normal saline? Sodium chloride concentration are the same as in plasma. Is the first choice crystalloid in postoperative fluid replacement, contains 0.45% normal saline plus 5% dextrose, contains 154 millimole per liter sodium and 131 millimole per liter chloride. Chloride overload decreases glomerular filtration rate. Wow. Yes. It's 5. Which statement is true of Hartmann solution? Is associated with hyperkalaemia due to the potassium content, causes acidosis due to the high chloride content, more physiological compared to normal saline, contains 154 millimole per liter sodium, 131 millimole per liter chloride, counteract acidosis, mainly due to the bicarbonate content. Yes, well done. Wala, Hosni, Nahla, Farouk. Dr. Tariq, thank you for your reply. Hi. Question number 4, transesophageal Doppler. It is an invasive monitoring of the cardiorespiratory function, measures the cardiac output, responsiveness to fluid challenge, less accurate compared to central venous pressure, engaging fluid management, useful monitor in the post-operative period, requires arterial line. Yeah, there's a mixed bag here. Some answer 2, some answer 4. It's 2. Useful monitoring in the post-operative period. No, we can't put transesophageal Doppler in awake patient. It should be asleep because it is something down the esophagus, like NG tube. It is an invasive monitoring, of course, not an invasive, but LiDCO is an invasive. Lithium-directed cardiac output monitor requires arterial line, so it's a non-invasive. Less accurate compared to the CVP engaging, of course, is more accurate than CVP. CVP is a lie, is a myth. CVP is an astura. Last question, post-operative fluid management. Fluid overload ensures quick recovery following renal transplant operation. Yeah, if anybody answers and put one at the right answer, I will quit medicine and work in a petrol station. Urinary catheter is essential to monitor urine output. Of course not. What about creatinine? Fluid overload can cause AKI. Houseman solution can cause hyperkalaemia because of the potassium content. We'll see. Dextrose 5% is ideal fluid replacement therapy. I didn't mention dextrose 5% at all in fluid replacement. Yes, fluid overload can cause AKI. It's not only AKI. You know, wound-related complications will be high with fluid overload. Tissues are edematous as well. Thank you very much.
Thank you very much, Professor Halawa, for this elegant, illustrative, comprehensive, and smart presentation addressing a very stimulating and points in this hot issue on transplantation. Before we start our comments and discussion, I would like, I can see on the chat, I would like to welcome some of our professors. I think we have Professor May Hasaballah, the president of the Egyptian Society for Nephrology and Transplantation. Hello, Professor May.
Assalamu alaikum. Thank you very much. Thank you very much, Professor Halawa.
Okay, I can.
I think this is a very good restart for our meetings, Professor Halawa. This was really very informative and very basic and very essential for everyone to know. I think all nephrologists should know these facts.
Thank you very much. Yeah. But, you know, surprisingly, you know, we know the facts. Sometimes we don't apply it. Still, we're looking after ourselves. You know, would like to see more urine output to please myself. However, I forget that.
I can't deny. I like to see urine coming out. Yes. True.
After stressful transplantation, I would be delighted to see more urine on any other expenses. So I stopped myself from overloading patients. I stopped myself from giving unnecessary medications like diuretics and mannitol. I stopped myself from not looking at the fluid balance and ask Anisha how much fluid you have given so far.
Very good.
Professor Halawa, you good points in your presentation, and I think that fluids are drugs. Number one, fluids are drugs. You should manipulate fluids as drugs. Number two, normal saline is abnormal saline. It is not normal in view of the high chloride content that cause hyperchloraemic metabolic acidosis. And balanced crystalloids are much preferred in view of the low chlorides. Also, one of the common practices in this regard is the use of low dose dopamine, on the assumption that administration of such dopamine in this low dose will increase the renal blood flow, and the belief that this protect against renal failure. However, studies on the efficacy of dopamine infusion in kidney transplantation are conflicting, and the majority of them actually fail to demonstrate any significant effect when dopamine was administered to the recipient following transplantation. And the conclusion of many meta-analyses that dopamine should not be given and should be eliminated from the routine clinical use. Another point about the colloids, that the use of colloids should be restricted to patients with severe intravascular volume defects necessitating high volume restoration, and the routine application of dopamine and the high dose of diuretics is no longer warranted. And mannitol is given immediately before declamping, reduce the requirement of the post transplant dialysis, but has no effect on the long term. So this is regarding the points of the type of the fluids used. Also, you addressed the monitoring, and I totally agree with you that the CVB should not be used alone to guide the responsiveness and should not be target for clinical decision regarding the fluid management. Also, a lot of meta-analysis showed that the correlation between CVB and the change and showed that only 50% of high-risk patients in the intensive care units and in the operating room who appear to be hypovolemic based of CVB were fluid responders. And other unnecessary on CVB and fluids, which can promote further administration of fluids. On the other hand, the use of pulmonary artery catheters, Swan-Ganz catheters, and so on, has fallen out of favor, concern about a lot of complications, such as pulmonary among the high-risk patients, pulmonary artery rupture, cardiac perforation, and so on, and the frequent misinterpretation of the waveforms. So, do you agree on that? And I would like also to, we have with us two dear guest Professor Riyad Saeed from Jordan and Professor Faisal Shaheen from Saudi Arabia. Of course, we need to hear from them their comments. Please, Professor Halawa.
Thank you very much for this comment. Of course, the dopamine renal dose is gone already long time ago, and there's no evidence to support it, and no one is using it in UK now. CVP as well is not in use at all, except one condition if we need inotropic support, need a CVP, but otherwise, won't put a CVP. And even if we put a CVP, won't measure the CVP. We use it as a line. I totally agree with you regarding the management, fluid management. Fluid management is an art, and we should be careful because the safety of the transplant, we should look at the patient rather than a kidney. So the patient has more than a kidney, has a lung, heart, brain, circulation, bowel, even the wound, which should be taken care of as well. So fluid balance contributes to the recovery of these organs. Now there are a few questions here. What type of transplant change the fluid management? You have room for maneuver with living transplant. Living transplant with kidney is going to work straight away, you know, on table. So you can, whatever type of fluid is not important. However, it's better not to have hyperkalaemia. It's better not to have this patient on the acidotic side. But deceased donor transplant is a challenge. They mentioned clearly in this randomized trial that, you know, plasma light is much better than normal saline in deceased donor transplantation. It induces less hyperkalaemia and more benign in terms of. But in reality, this is only one trial. Many centers is a mixed bag again. Some of them use normal saline on the ward for deceased donor transplant and Hartmann solution for living. And some will use Hartmann solution for both. But what we normally do is when the patient is able to eat and drink, let him eat and drink. Our body will sort it out. And let us stop interfering with the body physiology. What about the role of lung ultrasound in estimation of fluid status? Why to make it complicated, Dr. Abu Zaid? Flow chart, get it right. Get it right. Flow chart, fluid management, proper fluid management, aware of how many patients, how many liters of fluid this patient had in theater, what's the output, drain. I have no idea. We haven't done lung ultrasound in estimation of fluid status. But when I was in Cardiff, as per protocol, the patient used to have chest X-ray in the recovery. Why? Because it was more accurate radiologically to pick up early pulmonary edema compared to clinical. So instead of having chest ultrasound, which is done in the ultrasound department, of course, yeah, I don't know whether you can do portable or not. Just X-ray in the recovery might give you a clue.
So, Professor Halawa, what is the routine practice regarding the monitoring or in the operating theater and later on the ward? What's the routine? Do you use the TOD, post-operative, and then CVB and clinical parameters in the ward?
Yes, absolutely. I mean, you can argue, why not use a CVP? At least we'll give you a guide. All right. I can argue with you, why not use aspirin to treat rejection? Useless. And actually, the CVP, based on assumption that the right atrial pressure and the pressure on the right side of the heart gives an indication of the pressure on the left side of the heart is completely wrong. Can you get me a renal failure patient who has a good heart? They are hypertensive, left ventricular hypertrophy. Some of them are cardiomyopathic. Age as well is related to the cardiac changes on the echocardiogram. So I don't think this is true. And even if you read Merrick paper, who mentioned clearly a nice statement, using CVP as if you are using dice. اللي هو الزهر بتاع الطاولة. As a matter of luck. And this is one of the myths in medicine. Looks like medicine is not a perfect science, especially transplantation. It looks like we have chosen the wrong specialty.
Okay. So what's the routine practice in Sheffield?
A routine practice in Sheffield, actually, on the ward, no CVP. Actually, we don't have CVP anyway. We don't have. We manage to sell them, put them on eBay.
No CVP at all, Professor Halawa?
No CVP at all.
Even intraoperative?
Yes, this is what I was saying. Nothing. No CVP. Transvaginal Doppler, intraoperative, or LIGICO. And then patient goes back to the ward without central line. And I showed you one of the patients 18 hours after the operation. There's no lines in there, no CVP.
And
No,
you give the fluid replacement peripherally?
Yes.
If you replace fluid, you give it peripherally.
Yeah, the replacement is 24 hours, and then we'll ask him to drink.
Yes.
You said 18 hours post-op.
Yeah.
Yes, just 18 hours post-operative, and we CVP just depend on peripheral lines for replacement.
Actually, we after 18 hours, I wish that I can show you the slide again. Yeah.
Yes, I remember.
Please, if you please.
Looks like I have to intro. Yeah. This patient, was mobile 18 hours after the operation. So we finished the operation 5 o'clock on the day before, and this was next day morning. Free of line, eating and drinking. I will tell you a secret. We'll give them a cup of tea in the recovery when he wakes up from anesthetics. Later on, in the same night, light diet, piece of toast. Next day morning, light breakfast, drinking. Very, 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 very rarely to have this patient dehydrated because they have loads of fluid in theater.
So how long you are keeping the patient post-operative in the hospital? 4 days?
4 to 5 days.
4 to 5 days.
Yeah, 4 to 5 days.
And you remove the urethral catheter at...
It depends. From day 3 to day 4. And to be honest, some of the patients, I send the patient home with a catheter. My very thin wall bladder has loads of urological bladder operations. So it was unsafe. I would like to keep defunctioning the bladder for quite long. You need to keep the patient on the ward because of the catheter.
Even if it's stented in the uretrovesicle?
With the stented, yes. Yeah, I mean, some of my colleagues tie the stent with the tip of the catheter.
Yes.
So
to remove
the catheter with the stent together. But I don't do that. I prefer to, send them home and then bring them back 6 weeks later to remove the stent.
Okay.
But fluid monitoring on the ward is CVP free. No CVP.
So how much the range of the urine output per hour in the early post-operative period you consider? You consider it between 100 to 500?
Yeah, I mean, if 500, I'll start think about that. Something is not quite right.
Okay.
But 100 to 200 mL per hour. This is in the initial period will be satisfactory. But remember, when you ask the patient to eat and drink, the body will take care of its metabolism.
Of course.
But I think it's different when it's a cadaveric transplantation or a live transplantation, because in a cadaveric transplantation you don't get that much urine output like in the living. So
True.
maybe in the living you need to replace more.
Or you replace less, because the living is, the kidney is taking control of the internal environment of the acid-base balance metabolite fluid. So less care for living, more care for deceased, for cadaveric. The problem with cadaveric, if the kidney is not working, it's around 20%, 25% of these patients, they won't have primary function. So they require dialysis. But again, next day morning, I know this cold ischemia time is quite significant. This kidney was imported from somewhere else, long way down the line, and cold ischemia time 18 hours. Difficult transplant. Put a catheter in, transplant, and then next day morning is not passing urine. Day after, still not passing urine. Take the catheter out. No point of keeping the catheter. Catheter to drain what? It's not passing urine. So we'll take the catheter, we'll take the drains, provided that is not productive. Let him eat and drink as if he is a CKD patient, exactly back to square one, back to what he was before the transplantation. But we monitor him in terms of weight. We know how much fluid balance he is on, and we'll deal with it. If he requires dialysis, we dialyze him. But we keep him all the time 2 kilograms above what's called the target weight or the admission weight. We don't like to dry him up because this is no good for the kidney. But we don't like to keep him wet as well, because it's no good for the heart.
Professor Ayman, I would like to welcome Professor Riyad Saeed and Professor Faisal. Professor Riyad.
مساء الخير.
مساء الخيرات.
أهلا مساء الخير.
مساء الخير دكتور أحمد. متشكر جدا دكتور أحمد. I really enjoyed your talk. It's basically a good renal physiology talk that enlightened all the fluid balances that we face in a patient with pre-operatively and post-operatively, and nothing really better than the clinical sense and monitoring your patient, as you mentioned, mean arterial blood pressure, chart INOs, the earlier mobilization of your patient, as you mentioned, early feeding them. In fact, what I'll do, couple of hours after I see the patient in the ICU, I start giving them oral feeding. By the afternoon, we have them a free liquid diet, and then in the morning, they have a good full diet, mobilize them out of the ICU in the ward. And dopamine, that's something out of fashion, as you mentioned, and basically the crystalloid versus the Hartmann solution. As you mentioned, there is nothing much to add, except I'll say really it was a fantastic talk. Thanks to our society for enlightening us for this kind of meeting that has been resumed. Thank you very much, Dr. Ayman, Dr. Yasser, Dr. May, and finally, Dr. Ahmed, really for this nice talk.
Thank you very much, Professor Riyad. Thank you very much.
There's a question
Professor
here.
Faisal.
Sorry.
Professor Faisal Shaheen.
Yes, thank you. I enjoy your talk, Ahmed, as usual. Excellent talk and on time for all of us. We have a little bit difference, but all our aim is at the end that the patient should not stay in the hospital for long. Fluids should go out maybe in the 3rd or 4th day, and fluid we should avoid giving a lot of fluid just before the surgery, because the patient can go to pulmonary edema, and post-surgery, especially in living related, sometimes we face it as a challenge actually. Immediate post-operative, the patient can pass 1 1.5 to 2 liters in 1 hour, which is a challenge. This is a challenge which we have to be careful in fluid replacement and to start to have a special protocol to decrease it. And maybe at that time we will need to monitor the CVB even for 12-hour post-operative if the patient is producing a lot of urine, monitoring the output and at the same time the CVB. In our protocol, the patient stay in the hospital for 5 days only, and full is removed on the 3rd day with the stent inside, 3rd to 4th day. So we don't have stent. The stent will be, with the fluid when we remove it, and the patient start to drink from the 2nd day, and he can move from the 2nd day. So it's almost the same your protocol, and this is what we are practicing now. But as I mentioned, that the only challenge for living related is the very high urine output post-operative, which should be managed carefully. Thank you.
You know, Faisal, really, this is because, as Dr. Halawa mentioned, large volumes of fluid that has been given intraoperatively. Usually, they give around 3, 4, 5 liters. And this is really, we should take it into our consideration. That's what Dr. Halawa mentioned. Don't forget the OR, what's happening there. We are not there, they are there. Anesthesia record will help us a lot to see where we stand.
We consider that, Riyadh, and still the patients can produce 18 liters in 24 hours. And this
agree
is
100%, we face this, yes.
Yeah.
But again, usually we keep the stent, as Dr. Halawa mentioned, for 3 weeks at least. I'll keep it 3 weeks. I will not really take it 3, 4 days later. Foley catheter, we'll take it 4th day, 5th day, basically. That's what our practice. But stents usually stays for 3 weeks. It's a little bit different from what you have, Faisal.
Yes, thank you. Recently we started to have the Foleys with the catheter and go out, because again, it is a financial burden for the patient to come again to be readmitted and to do cystoscopy and to remove the Foleys. This is again a money thing, but it's thanks to my son Muhammad. He is the one who makes this implemented, and it goes very well.
That's a good thing, yes.
Yeah, I think, as I mentioned, Professor, some of my colleagues tie the stent into the catheter to remove the catheter with the stent together. But, for me, because most of my transplants are a bit challenging, so it's a habit just to, to leave the stent for 6 weeks and bring them back as a day case, cystoscopy and removing the stent. Of course, having the stent and the catheter in one go reduces hospital admission and all administration and cost involved as well. Yeah. In UK, there are more than 8 centers, major centers of transplantation. Can you believe it? 8 centers with 8 different protocols, 8 different immunosuppression regimen, 8 different management protocol. Difference enriches us. We learn from each other. We learn from our mistakes. We learn from other mistakes, and we learn from their experience as well. So accepting the difference is something we should implement, that we should accept that we are different.
May please unmute yourself. I see that. Unmute, Dr. May. We couldn't hear you.
Dr. Ali Taha?
Professor Halawa, I just want to ask you, what's the drawback of removing the stent early, 3 days or 4 days?
There's no drawback.
No drawback.
At all. Actually, in the past, we used to transplant without a stent.
Without stent, yes.
And when I was in training, I had to justify to my boss why I use a stent. Is it thin wall bladder? He used to question, is it a thin wall bladder? Is it difficult anastomosis? If the answer is no, 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 then his next question, what did you use the stent then?
To sleep
well, put more plastic. But It's well known fact that stent can protect against obstruction, mitigate the early urological complications, but do not prevent them.
Mm-hmm.
If you have a cookie anastomosis, whatever you do, stent, million stents won't help it. If the bladder wall is thin, stent won't help, but it gives some reassurance that if I try to go back in again, I can find the ureter. Because reoperating on these patients will be quite challenging. You know, we'll call it hot abdomen, you know, all the inflammations and the previous surgery, especially recent one. I need to identify the ureter. Stent sometimes helps that I can feel this is the ureter here because I can feel the plastic tube. But this is not the indication for putting a stent, it's for reoperation, but it helps.
And it's not without complication using
infection.
stents. We conducted a randomized controlled study 5 years ago, a group with a stent and a group without stent, and we found a significant infection in the group with stents without any adding benefit regarding the leakage and the communication. So I think stent should be inserted in selected patients with thin bladder and so on. I mean, the decision is intraoperative according to the situation.
Professor Ali Taha wants to comment.
السلام عليكم. welcome all, دكتور أحمد, دكتور رياض, دكتور كلكم أهلا وسهلا بكم. دكتور أحمد, my question about polyuria, marked polyuria after transplantation and early preoperative. We faced many patients in Sohag Transplant Center with marked polyuria, about 18 to 20 liters per day, even for 1 week or 2 weeks postoperatively. How about think maybe judgment of fluid may need a replacement with CVB? As you mentioned, CVB is not accurate. How about what we can do in this situation?
Fine. So why we have polyuria to start with? We should prevent it.
It is
nephrogenic, diabetes insipidus, but this is actually more with cadaveric transplant rather than living transplant. Sometimes we have nephrogenic form of DI in deceased donor transplant. Have you tried mineralocorticoids?
Yes, at that time we tried, and one case is improved, and one case continue for about 3 weeks for polyuria, and then start to improve.
Yeah, this is actually because of the kidney. This is something wrong with the kidney. Basically, it looks like a nephrogenic form of DI. But will you keep the CVP? As if we are chasing our tail here, Prof. Ali. So pushing more fluid, more urine, more fluid, more urine, more fluid, more urine, it will be endless. Sometimes we are driving the polyuria. It happens here, transplant practice has never been a perfect science and will never be a perfect science. Next day morning, he had 16 liters and past 16 liters. We must be driving this polyuria. We'll weigh the patient. We'll see where he is compared to his previous weight, and then either to stop fluid. And how we stop fluid, we don't stop fluid abruptly. We give him, let's just say, 2 liters over 24 hours and ask him to drink and monitor him closely. But if he kept giving fluid, he would pass it because he's already overloaded. What's the weight? Actually, the scale is more important, million times more important than the CVP.
This is heterogenic, Dr. Ahmed.
This is what I mentioned with cadaveric transplant. we see this sometimes that, you use polyuric because of the, polyuric phase of renal failure.
Yeah.
And kidneys recovering. But there is no reason for living transplant to have this problem unless we are driving it.
Professor
Use me to
Faisal?
command. Professor Faisal?
Please unmute yourself, Professor Faisal.
I agree with Prof. Halawa. We are facing this case like to have 18 to 20 liters. The only solution for such patient is to restrict the fluid intake. So not to give the previous one. Usually in my order, I said if it is more than 600 cc per hour, decrease the intake by 30 and then by 50. Once it goes up, you decrease the intake, and by this, you will start to control the urine, the maximum urine, the urine output. This is how we are dealing with this. And second day, you can even stop all the fluid and give 200 cc per hour in order not to make him depleted. And you will see that the kidney start to concentrate and reduce the urine by itself.
Yeah, true. Yeah.
I think relying on the body weight, as you mentioned, and the changes in blood pressure, and to have blood pressure erect and supine to avoid the postural hypertension. I mean, these could help in managing such patient. And I think what's Professor Ali describing is an over infusion. It's not the case that needs mineralocorticoids or not. I mean, this is a common practice in the transplantation. So we have to modify and put a guidelines for the fluid management in the early postoperative or the perioperative period. And I think we should have the anesthesia people with us, because what's happening in the operating theater is over infusing the patients, and we have these the sequelae of these in the early postoperative days in the ward. So I think they should change their mind also regarding the fluid intake in the operating theater.
I think when the kidney functions are back to normal or near normal, you don't have to replace. I think you just let the patient eat and drink, and then the kidney will take it from there.
Yeah.
So what we do sometimes is that we keep on replacing the lost urine, and this will go to a vicious circle, so it will never end. So we have to cut down on the replacement as long as the kidney is functioning properly and the patient can drink well, and then it will control itself.
Yeah, my main point here is, instead of carry on replacing and discussing which one is better, normal saline or lactated ringer or Hartmann or all these fluids, let him drink, let him eat.
Yes.
يعني ربنا خلقنا يعني وأحسن يعني أحسن خلقنا، فبالتالي the body will deal with it. As normal, the body will deal with everything. Just don't interfere.
Yes.
don't make it worse.
I think we should pay attention for the cases of delayed graft function, and this is the challenging to have a fluid balance in such patient rather than in the straightforward cases. I mean, how you don't monitor such patients with any any techniques or aids with only the clinical and the flow chart and the body weight and nothing additional.
Yeah, I will give you one example. Patient came in, his weight is 66 kilograms. After the transplantation, kidney is not working in delayed graft function because you got a cadaveric kidney imported with significant cold ischemia time. Next day morning, his weight is 70, so 4 kilos above the dry weight. Do you need a CVP?
No.
It's very clear that he's 4 kilos above his admission weight. I'm a bit embarrassed to say dry weight because, as I mentioned earlier on, dry weight never been dry, never been the actual weight.
Yes.
Even the target weight is almost unknown for all CKD patients. It is just a guesswork. So 4 kilos above his original weight, I don't need anything else, just the scale. الميزان بس، بيني وبينك الميزان ولا نوزن بره.
Excuse me to comment and ask at the last one. We are approaching 2 hours, Professor Halawa. Thank you.
Yeah.
Thank you, Professor Ayman, for this highly interesting.
We are enjoying, Victoria. We are enjoying.
Yes, you are much more enjoying. and I want to add that it's the first time to have the answers on the chats like this. Your lecture was so clear and informative that we have all the right answers clearly, and many of the audiences answer the right answers. We usually have 1 or 2 answers. I want to add to comment about the lactic acidosis that occurs with the use of normal saline. Yes, we face it even in critical care situations apart from the transplant. The patient usually we faced with metabolic acidosis that we say that it may be due to AKI, it may be due to lactic acidosis, something like this. But once we change to Ringer solution and decrease the amount of normal saline, the acidosis improves and the patient condition much more improves. And we faced this many times. Thank you for highlighting this point, Professor Halawa.
And more importantly, Professor Yasser, ask him to drink.
Yes.
And back to normal
Totally.
diet as soon as possible.
Yes. My questions, or I think it will be the last question in this. Sorry for overloading. About monitoring using the IVC diameter, and you said that intra-abdominal pressure is raised. What about do you routinely measure the intra-abdominal pressure in this situation?
Yeah, but they did before. They measure intra-abdominal pressure before with in critically ill patient. It's easy to do. Intra-abdominal pressure can be measured through a catheter into the bladder.
In the blood.
Intra-abdominal pressure can give you indication in centimeter water how high the intra-abdominal pressure. And there is a disease called abdominal compartment syndrome. This is actually well known for surgeons, who deal with abdominal surgery.
Yes.
So but imagine a massive retractor like the Omnitract, 2 pair of hands inside the belly, packs everywhere, patients tilted.
Yes.
You have good reason to have intra-abdominal hypertension.
Later on, post-transplant after removing retractors, no place for measuring intra-abdominal compartment pressure, intra-abdominal pressure?
You are inducing intra-abdominal hypertension.
Yes.
Yeah, because the retractor is a metal work. It's heavy metal inside it's compressing the IVC, compressing everything. So,
I'm speaking about post-operative.
Yes. Yeah. No. Why do you need to measure it?
You said that it is there is raised intra-abdominal pressure, fluid overload makes more and more, and maybe some sort of monitoring. I'm asking about the use of this tool.
Yeah. I mean, no, we don't use it in transplantation like enough, but we use it in general surgery.
General surgery.
Yeah, after major, very complex abdominal operation, the intensive care itself, they measure every now and then.
Yes, this is my question.
Yeah. But lucky enough, we don't need to do this for the transplantation.
And about IVC diameter?
No, life is simple. So let us not make it complicated.
But transesophageal Doppler is more complicated.
It is just for a few hours in theater, and that's it really. Because, in theater, the environment is completely different. There is a big wound, 2 surgeons diving inside the abdomen with the metal work, heavy metal inside. Patient is tilted, twisted, the patient on a ventilator, post-pressure ventilator. So we need to have some monitor about the fluid, because many of these patients, especially hemodialysis patients, are dry before coming to theater. If they have dry patient and put a cadaveric kidney, it may not work at all.
Ahmed, do you have any special consideration or precaution decision of pediatric transplantation regarding the fluids?
I stopped dealing with pediatric transplantation 20 years ago, so experience is out of date, to be honest with you. And actually,
So,
when we were doing pediatric transplantation, pediatricians were a bit,
Professor
touchy
Ayman.
about interfering with their patients. So we used to do the, the surgery and we'll leave it to the pediatrician.
okay.
We're not welcomed by them.
They are losers. Okay.
Okay.
Okay. I think we
Professor
come to the
Ayman?
end. I think we come
2
to the
hours.
end of of this interesting presentation. We're always happy and honored to have Professor Halawa with us. And really, I enjoyed, and I think all of us enjoyed his presentation and touching
Yes.
and addressing a very, very important and hot topics in our clinical practice. Thank you very much, Professor Halawa. Thank you very much, Professor Yasser, for the organization, Professor May, and our dear professors and guests. And see you, inshallah, in next. I think it will be after 1 month, Professor Yasser, the transplantation.
1 week.
No, I mean
1 week.
okay.
Transplantation
I know.
will be about 2 months.
2 months, okay. Okay.
About 2 months.
And the next week
we have
we'll...
next meeting. Just about 2 months. Thank you, Professor Ayman.
Thank you very much.
Yes, thank you, Professor Ayman, for this highly informative and fruitful meeting, and hope to meet you all again in the next meeting by hemodialysis chapter. Hemodialysis prescription by Professor. Thank you all, and excuse me to Professor Ayman.
Thank you very much. Thank you very much, Professor.
Thank you.
Thank you. Bye-bye.